Hello and welcome to another Polestar Pilates Hour webinar. Today, I get the opportunity again to meet with Nichole. She is our Director of Curriculum internationally and runs our education program with Shelley Power. And we're super excited to talk about a case that Nichole and I had the chance to collaborate on. First, it was on the phone, and then it turned out that I was visiting her and there are other children in Utah, and we were able to make it work. So it's an exciting case that we get to present together. And Nichole, always good to have you on the webinar. You are very articulate. I always get a lot of compliments on how graceful you are. And I think, I'm not sure where she got that grace from. I don't think it was from me. I'm not very graceful. Anyway, welcome, Nichole.
Thank you. Excited to be here. This is one of my favorite topics. So
besides the topic we're talking about, what people are coming on, anything like super interesting that you're working on in the curriculum and development world for Polestar?
a big push right now is to provide more resources for students. So maybe one of the things, if you've taken a Polestar training with us, you know that we require observation hours and practice teaching hours and all of these things. And it's actually really in line with this idea of collaborating, in that one of the best ways to learn is to observe and to participate and have that back and forth. And so trying to build some resources where our students can observe remotely, where we can film things, where our students don't have to, especially if you live somewhere where you don't have that resource live, that there is that filmed resource to kind of see what people are thinking about. And we'll talk about this a little bit later, but when a really big growing thing for me was to get to watch a physical therapist work and ask them questions and have them kind of just verbalize, this is what I'm seeing, this is why I'm doing this. And so to try and build some more of those resources for our students, it's probably our biggest thing that I'm kind of working on right now.
Yeah. A lot of these things we take for granted based on our work experience, where you had all those years working at Pinnacle and being surrounded by therapists, and anybody that worked at Polestar Center in Miami was also surrounded by the PTs. But we often take that for granted, not realizing that most Pilates studios do not have access to that collaboration and to learning how to communicate successfully between the professions, with the most important interest being that of the client. And I think that's a good place for us to start today. I do want to do a couple shout outs on some individuals who joined us. So our licensee from New Zealand, Marie, thank you for joining us. I see individuals from Poland and Paris, Austria, Canada, Scotland, Croatia. Mirella, nice to have you on. So thank you all for joining us today. And we're going to jump right into this case. We've got lots to talk about. And I'll just preface it that this is Nichole's case and client. And I'll let her tell a little bit of a story. Before we go there, I have a couple questions that are important for us as it pertains to how we move forward with this collaboration discussion as to who's here. So the first question before I turn over to Nichole is, which statement best represents you regarding your relationship as a Pilates teacher or as a PT or both? The one that concerns me is being a Pilates teacher with nobody that you're working with. And that's really what we want to accentuate today. We would love to have feedback from the first and the third as well, who have successfully either are a healthcare practitioner working in Pilates, or a Pilates teacher that are successfully working with healthcare professionals. So this one's the majority of experiences I have had collaborating between Pilates teachers and healthcare professionals has been, and just to give us an idea, and I know sometimes in both directions, and we'll be talking about that towards the end, of why sometimes people don't have great experiences in doing that. So hopefully nobody's having negative experiences, but there's times that we don't necessarily have a positive experience either. Nichole, how would you answer this one?
For me, it's been very positive across the board. But I think I've been really lucky to have a lot of connections in that way. And I understand that students don't always, or Pilates teachers don't always have that available. So even in our trainings, I always recommend you try and find someone who you like, who you get along with, who you can connect with.
I mean, it's all the way across the board. I mean, I've had to do that with physicians. There's physicians that are belittling and condescending to PTs and anybody that's not an MD. And there's others who very much respect the work of a PT and vice versa. And what I learned in the military, Nichole, was I did a couple internships there, was everybody was on the same rank. And so everybody communicated and had to work together with the best interest of the soldier, not all the condescending authority between the doctor, the therapist, the nurse, etc. Well, this is good. So we do have a little bit, I know it happens. Whoever had definitely a negative experience, I want to promise you that you can make it a positive experience. We're going to hopefully give you a good model to follow. What would help to facilitate collaboration between Pilates teachers and healthcare providers? So if you had, it's an open question. If you had a really good experience working with somebody, as Nichole mentioned, write down what it was, right? Often in Polestar, we talk about meaningful feedback, and it's not just good enough for us to say that was really good or that was really bad or it needs to improve. It really was more about what about it was good? What about it made that a positive experience for you or a negative experience? Yeah, I'm glad I see communication up there right in the front of it, because communication, like any relationship, is probably one of the most important elements. Yeah, I like the one that healthcare providers had a better understanding of how we work and what we can do and the knowledge we have. A lot of times they have to go through these experiences too. It's amazing how humble a healthcare provider will be when they realize the power of the work of a Pilates teacher or gyrotonic instructor. Anything jump out at you, Nichole?
Well, I think that this idea of a common goal for the client is really important, because that's how everything will work together. If your main goal is to support the client, then you'll do whatever it takes. I think it's important to not feel like, oh, I'm going to lose my client or I'm going to lose money or something like that by collaborating. So I think it's important that the client remains the main focus, and that's what makes it work. And, for the healthcare professional to be happy that their client is discharged, essentially, knowing that, maybe in the future, they might be called upon again to support some other things that might arise, but not trying to hold on to a client just because that's not in the best interest of the client.
Right. As a therapist, one of the things that is important to me, both in both directions, I often feel like I'm in the middle, right? So I have physicians and surgeons on one side and Pilates teachers, yoga teachers, gyrotonic teachers on the other side of me, and try to liaise that continuum of intervention for the client and understanding things like language. And so somebody put communication up. And if I was to do a medical diagnosis of a patient, that would be outside of my scope as a licensed physical therapist. And so I would not call a doctor and I would not use language like, I think this person has, ALS. That would be a major faux pas on my part from a communication standpoint. But what I would do is I could call the physician and say, I have a client who has, these signs and symptoms, and I feel like they're outside of my scope. And that kind of communication opens the door for them to say, hey, thank you. Wow, you identified some signs and symptoms of something that's really important. And I remember one case in particular, I had a patient sent to me by a physician for low back pain, but it turned out to be a descending aortic aneurysm, and a very serious one. And I realized that what I was seeing was not about back pain or musculoskeletal problems, and sent him back to the hospital and did that sort of diplomatic communication, knowing that it was something wrong with his vascular system. And, the next week I got a big basket of cheeses and wines and salamis and fruit and things because of the respect that they had for me identifying it, even though I didn't diagnose it. And I think the same goes through where when a Pilates teacher, and Shelley is masterful at this, so is Elizabeth Larkham, of being able to identify, and you do real well, Nichole, with this, of identifying what the symptoms or signs that you're seeing and doing it in a very humble way of, I noticed this, and this, and I think that they need a consult with you. And that is a beautiful way of consulting back and forth. And likewise, once we establish that rapport, sort of in that spectrum of care, it gets very easy to communicate these things. And there's a lot of respect in both directions of the expertise. And one of the things I tell my Pilates students is, if you want to meet expert movers, meet some of our Pilates teachers. Do not assume that because you're licensed, that you know how to teach movement better than a Pilates teacher. That would be a very false assumption. And it's something we learn to respect, and that has to be taught all the way through. So there are times where typically the more self-conscious, the person that has a bigger ego is less capable of communicating across different professions than somebody who doesn't.
I'll give a little background about my client, Adam. He is a 45-year-old male, and I actually got him as a kind of a handoff. My mentor ended up moving, and she had a few clients who she kind of transferred over to me. And Adam had already had a really profound experience with her. So when they met, he was unable to lift his arm at all and was thinking he would need a total shoulder replacement. And actually, I just recently learned this story that she had just seen him at some place, I don't know if it was a concert or something, and she noticed that he was struggling to move his arm. And she said, "Hey, are you having some issues there, I guess?" And that's how they met. She kind of saw that he was struggling, and that's how that relationship was born. So I thought that was very interesting and a very organic way to help someone through their movement journey. And so through working with her, Adam was able to gain, almost, up to 90 degrees almost. I think maybe he was able to lift a little bit before. And that was really profound for him. And that felt really good for him, that was a range of motion that far exceeded his expectations, and that he was also able to avoid surgery, which was really important. And she had put together a program that he really enjoyed and still enjoys, and liked doing very much the same type of thing every week to maintain. He has a very active job. He's a contractor. And so he does have to do a lot of work with his body. And so this really helps him kind of maintain. And I kind of started there with him. And we've been working together now maybe 8 months or so. And I just had this feeling, I thought, I think we can do more here. And maybe I need to have a better understanding of what happened to his shoulder in the first place. And 8 months ago, I'd spoken with my mentor about it, and she had probably told me, and I lost that paper. And I thought, let me just ask him what had happened. And there was no significant event other than he said it started dislocating a lot, and then it froze. And a lot of my experience with dislocations in shoulders are usually anterior, and I just wasn't seeing it in the same way that I normally did. And so I was kind of wanting to make sure that anything I did, didn't bring those dislocations back, right? Just from a basic understanding of guarding often happens for a reason, and that, I didn't really know those reasons. And so that's kind of the basic. And I want to just emphasize that he's happy with his current range, and that when I broached this subject of perhaps exploring if more range could be had, I wanted to be really careful that I didn't make him feel like the range he had wasn't good enough, or that there's some other issues. He's very confident, so I wasn't concerned. Some people are not as confident with their bodies. So you can adjust things accordingly depending on the actual client. But I did broach it, and I said, what do you think about maybe trying to get a little more range? Because I think it's something we can explore. Maybe, I know you had imaging done. Maybe we can look at that and see what the real tissue damage is. And maybe that can inform us. And from that moment, we kind of started this dialogue, and that's when I knew, okay, now I need to know how to proceed, and I need to talk to someone about this.
I think it's, Adam's also his history of playing professional baseball. I mean, he's like 6'5", very tall, very athletic looking person. So I think it's interesting how you approached him on increasing his activity when he at this point is satisfied with where he is. I think that's a very sensitive point, as you mentioned, and it takes some skill to approach that. I think sometimes we speak as if we're thinking for them without seeking to understand them. So that was a very important point that I think you brought out, Nichole's, how we obviously want him to move better. We obviously want him to have more range and more strength. And yet he is saying, I'm comfortable where I am. It was so bad before. I'm really happy where I am right now. And so how do you approach that?
Yeah, and before we go on, I see Sarah's question. His objectives actually had not changed when I took him on. His objectives were to maintain, and still is right now, only able to come once a week. And I think in that 1 hour session a week, it felt like it was really important to do the maintenance. And then I think he has this idea that maybe if we can get to 2 times a week, then we can have the time to put in to address some of these other things and start to actually improve things. So it was definitely on his radar, but I wouldn't say that it was the most important thing on the radar. It's very important. It was very consistent. So it's very important that he comes out 1 time a week and gets that movement. And I just felt like there's got to be a way I can insert a little more into that 1 hour to maintain and maybe start pushing the needle a little further.
So this was a little bit of my conversation with you and with him, but just asking him, my typical question of what he believes he should be able to do, he's not able to do. And he was very clear and even showed me that he just, he doesn't have overhead activity. He's a general contractor, so he's not necessarily the one that is doing as much of the construction anymore. He oversees it. He's the boss. He's the general on this. But when I asked him what he believes prevents him, he just is like, it's blocked. I'm unable to lift over my head. I don't have the range of motion. And if he pushes it too hard, there is pain at that end of range for him. So I think that's probably why he was sort of satisfied. It's like, I just don't want to be in pain. And I just want to, I don't want to recreate pain. I've already been there. I've had that a lot. So Nichole, you want to talk about his history, and then I'll take the next one.
So like Brent mentioned, he was a professional baseball player, a pitcher specifically, and the shoulder in question that's limited was actually not his pitching shoulder, which also kind of surprised me. I was like, what happened? His pitching shoulder, and I think maybe there is just lots of wear and tear and maybe even some laxity in general, because his pitching shoulder did have to have repairs. So it's very tight in the joint in probably a good way for him. And he has full range of motion, but it's definitely stiff because he's had all of that repaired, because it was pretty much all torn in some way at some point in time while he was pitching. And so that's the right shoulder. And that's his dominant arm. And what he does actually do framing work and stuff where there is a lot of hold your arm overhead. And so his right shoulder not only is stiffer just because of the surgery, but also because he has to use it for the majority of the work. And that kind of has created stuff all the way down the chain. I didn't write it here, but just pelvic torsion and things that kind of are recurring, and some SI pain, things like that, just the 1 hour a week of Pilates. And I think he did a lot of intensive work with my mentor in the beginning to work on his pelvis and his hip on his left side. And, it's this kind of diagonal change. So I also think that by getting some more movement restored in the left shoulder, it will create some balancing things in that way as well. And then when I did that further history to ask him more about his left shoulder, he said he thinks he fell. He doesn't really remember exactly what happened to create that dislocation, but he fell and landed on his arm. So, he'd said he thought it was a posterior dislocation. I remember thinking, that's so unusual, right? Because I've never worked with someone with a posterior dislocation. And so it was new for me. I wasn't really sure what to look for, and I wasn't sure if he had it right. You never know as a client telling you the right information. And it started after that fall, it started dislocating a lot. And then at some point in time, stopped moving completely until he started working with my mentor, and she was able to restore a lot of that range.
Nichole, maybe before we talk about what I found in my visit, let's talk a little bit about what led you to want to look at some, manual therapy intervention. What were some things that, you'd gone through as a Pilates teacher that led to that?
Yeah, so some of the work that Danielle was having him work on, that's my mentor, call her by her name, so secret. Some of the things that Danielle was working on with him was a lot of boob work with shoulder work, some alternating things. And when I had my discussion with her, she had mentioned maybe doing some of the side lying work to get that range. And all of that he can kind of do, right? Because the gravity is pulling his arm there. But it just never felt like it was improving. I wasn't seeing a seating in the glenohumeral joint that I would be looking for. And it didn't feel like I was able to achieve it with kind of the normal things I would maybe try, which would be some of that oob work, no angels, which is like doing a snow angel movement on the oob, alternating arm marks, openings, and just, it wasn't really making it seem like it was more congruent. And so I was like, okay, well, those are the normal things I try. Weight bearing, just he's not very confident in weight bearing, which would be another approach I would take, right, to kind of find some of that congruency in the glenohumeral joint. And then I thought, well, let's just see what, I knew his scapula was not doing a true upward rotation, right? It was doing an elevation when he was lifting his arm. And he can passively have his arm up. So when we do a lot of movement, I would control his arm to bring it through the ranges of motion. But I was never seeing this integration of glenohumeral joint scapula, and I wasn't really sure how to approach it. I tried doing seated pull down and giving some of that cueing. And so I called Brent and I said, this is what I'm seeing. These are the things I've tried. And this is where it's really convenient if they know the Pilates repertoire, because then he said, okay, what if you have him do seated pull down where you hold the bar still so that he can't pull the bar down, and just have him pull and pull and pull and see if it gets his glenohumeral joint to kind of seat a little more. And that's something I hadn't thought to try. So we did that and it seemed to improve a little bit, but he was still, it was just not going. And then I thought, well, maybe his lats are restricted or something through here is restricted. So I tried some work where I gave some cueing of like just some gentle pressure down through this muscle to see if his scapula could move separately from it. It didn't really do much. I thought, okay, my dad, he's coming in town soon. Brent is coming in town soon. Let me see if you can see him. Adam had one really successful work with a physical therapist who Danielle's collaborating with, and he had done some dry needling down through there. So when I was like, I wonder if your lats restricted or something, he said, oh, well, actually, I did dry needling once, and she did a lot of dry needling through this area, and I was able to lift my arm. And I said, well, that's amazing. And I said, is there a reason you haven't gone back? And it was just kind of like timing and this particular clinic, this physical therapy clinic is 40 minutes away from us. So, just something that wasn't a big enough problem, I guess, to go and do that. And so I had said, well, maybe you should go work with her again. Try it. Let's see if we can have that range restored and we can start working through that bigger range. So that happened. And then I knew that Brent was coming into town. I said, well, can you just come see him? Just tell me what you see, because it looks different than what I've seen before. And then he'll tell you, it was posterior, which was something I just had never seen. And I think that's an important thing to note, is that, okay, I've worked with a lot of people who have their glenohumeral joint very anterior. And so a lot of the strategies that I would maybe use to work on congruency are different than when it's posterior. And I'm still kind of learning about how to work with that.
Well, the laxity is in the posterior capsule. So most shoulder dislocations are from the arm going back and the shoulder going forward versus a fall. And that does make a big difference, because you think of his guarding pattern, his subscapularis is what was really holding down. I'm pretty sure that the needling, the dry needling, was probably addressing that, and the serratus anterior were the two areas that were most guarded down to try to stabilize that area. And he was sitting a little posterior in his capsule, and that's why you couldn't see the congruency happening there. And if you don't have congruency, you can't find rhythm. So we talk about this a lot in our knees. We talk about bone rhythms, right? We talk about this in our hips and our feet, and how important it is to have that right relationship and that congruency to be able to have movement in those joints. And the shoulder is no exception, except for it's a very hypermobile joint to begin with, which is not bad. It gives us dexterity. But the fact that you don't have structural integrity in the posterior part, and this is a really important point to bring up, is that when you've lost the static stability or the non-contractile stability, talking about capsules, ligaments, those kind of tissues, disc, labrums in his case, in the shoulders, then the neuromuscular system has to compensate. And the neuromuscular system doesn't have great proprioception like the inert structures do. So the receptors inside the ligaments, inside the capsule, inside the different cartilage is very accurate because it doesn't displace a lot. So it tells the brain, your shoulder's right here, where a muscle can stretch a lot, right? And a tendon can stretch a lot. So the Golgi organs and the muscle spindle fibers inside those tissues are giving messages all the time, but they're not as accurate because they can conform to the new position, right? So if he's laying on his shoulder and his shoulder is here that night, then his muscle spindle fibers think this is congruent, right? Where a capsule wouldn't think it no matter how you stepped unless it was deformed. And so because of the dislocation, he had deformed his capsule. And I think that's, when we're looking at these kind of things, Nichole's picking up some of this loss of strategy. The scapular rhythm was lost. Why was it lost? Why was he sitting outside of the glenoid fossa? Why was he displaced? And these are the kind of questions that, as Pilates teachers, you are completely legitimate in asking these questions and trying to figure it out. And trying to figure out, as we mentioned, are you able to, cue it back into place? Are you able to use load modification, which Nichole talked about with the tower bar? Are you able to use a little bit of resistance to be able to re-educate the muscle? And the answer to all three of those is yes. That completely falls within your scope of practice as a Pilates teacher. And that's what Nichole is doing. So let's go to the next slide and see what I found when I saw him the first time. And these were some just real quick objective measures and observations that I made of him. Just, tall, this good-looking, athletic man, sort of a little envious of how strong he looked and how happy he was. Right shoulder was sitting a little anterior, left shoulder was sitting a little posterior. And when I looked at his active range of motion, his left shoulder flexion. So active is different than passive. So Nichole talked about when he's laying down on his back or on the oov, he would have an additional 30, 40 degrees of range of motion. But active, standing up trying to lift, he was able to lift his shoulder flexion to about 85 degrees and abduction about 75 degrees, even a little bit harder. And it makes sense if you can imagine that head of the humerus sitting posterior on the labrum. It's going to bump up against the acromion. It's going to minimize the ability for the scapula to rotate up, which is what it needs to do for both of those movements. His power was pretty strong below 80 degrees. So if I looked at him being able to move down lower, grab things, pull things, push things, he was a 4 out of 5 in the left shoulder. But if he was to go above shoulder height, he immediately lost a lot of his strength. So it was less than a 3 out of 5. And when I looked at the passive range of motion, truly of the humerus, The glenohumerus joint was about 110 degrees. And then if I allowed the scapula to move, I could take him up to, 130, 140 degrees. But it's important to understand the difference between the glenohumeral movement and the scapular movement. So in a healthy shoulder girdle, the ratio is 2-to-1. So for every 2 degrees of glenohumeral abduction or flexion, there should be 1 degree of rotation or upward rotation of the scapula. So it's a really straight relationship. And if a scapula and glenohumeral joint couldn't get to a certain point, then he had to hike his shoulder up to get to that range of motion, his hand overhead. Movement strategy, we said elevation of the scapula, lift hand, poor scapular rhythm. Neurological was intact. Sometimes we've got to check that and see maybe what he had was a neck injury, and a neck injury can cause instability and weakness and inability to upwardly rotate. A C4-5 injury can cause scapular deficiency in its rhythm. 5-6 can cause weakness in the biceps and some of the other muscles around the shoulder that would be necessary for shoulder elevation, but he was intact. Special tests, there was a lot of noise. I don't know if you remember that, Nichole, when I was sweeping his shoulder and he's like, wow, that's really noisy. And it's like, it's okay, it's just rust. It's been non-mobile for a while. And then functionally, not very good weight bearing tolerance on the left shoulder. Left arm couldn't lift higher than 80 degrees, unassisted, and 100 degrees with assistance. So, that was sort of my quick take with him. Let's go to the next slide. When we look at overall limitations, looking at our NAGI model or our ICF model, decreased active range of motion left shoulder, poor scapular mobility, and what appeared to be soft tissue restrictions. From a functional standpoint, overhead activity was very minimal and poorly organized, minimal work restrictions, general contractor. So he's not like he couldn't do his job. He's doing his job and his work, but his recreation was limited if he was to go back and do anything that he used to do. And I think there's an important point to make here is he was satisfied with his current status and his current level of participation. So we want to be careful not to overstep that. That was something that Nichole brought up nicely. We have 2 questions. Let's see, real quick. Abby asked if I could explain the sweep. And the sweep was just, I was holding on to his shoulder joint and I was literally doing circumduction and flexion and adduction, horizontal, looking to see what I feel inside the joint. So just think of it as if I was sweeping the joint around the edges and seeing what happened. Sometimes if there's an acute labral tear or something, there'll be a big clunk or something of that nature. But crepitus, the sort of crunchy noise, that's very normal. I think most of us, if we danced or played sports and we're over 40, have some crunchiness in our bodies, maybe even younger. Sarah asked, can you explain crepitus, please? So crepitus, I always say crepitus is like it sounds. Crepitus, it's the noise that a joint makes. It's the snap, crackle, pop, where we say the Rice Krispie of the joint. So a lot of us, if you think of when you squat and your ankles or your kneecaps make a lot of noise, that's considered crepitus. As a joint degenerates more and more and more, it might have more and more decrepitus. It's sort of a harsh word in itself because it sounds like decrepit, but it really just means that there's noises inside the joint. Okay, usually cartilage noises of the bone rubbing up against each other. Let's see, physical therapy. So basically, I don't do any physical therapy without education. So the first thing I did with Adam was teach him about shoulder mechanics. And whenever we can do that, and strategies and patterns of movement, they become the owners of their movement. It's not me doing it for them. They need to understand their own body. They need to understand at whatever level they can understand. And it's very important that we teach it at a level that they can understand and give demonstrations of what good shoulder mechanics are, why his strategy potentially, could be a problem for him in the future if he continues to wear his shoulders down in the way without being congruent, right? So loss of congruency can lead to further degeneration. Postural education, again, taking just a simple Gertie ball and putting it up against a wall and having him start to find his new rhythms. But most importantly, my role in this particular case was the myofascial release and the soft tissue release around the joint capsule and a little bit of joint manipulation in the shoulder joint capsule. And, Nichole and Danielle had done a great job restoring so much more than what he had and the confidence to work in that range. And we went in and did some very basic myofascial release and soft tissue mob and transverse tissue work and a little bit of manipulation into the glenohumeral joint itself, the thoracic spine. And we were able to restore about 70% of his range of motion in that left shoulder, particularly in the glenohumeral joint. And so he was pretty surprised at it, but immediately we went into the postural education portion of it so he could feel and be in charge and realize that he was rolling the ball up the wall and getting his arm up to about 120, 130 degrees flexion, even though he didn't have the strength for it yet without the ball, that the ball and the wall basically allowed him to push into it a little bit with his pecs and stabilize that while his scapula now could glide once again. And I forgot to mention the other tissue that we moved was the serratus anterior. So being able to release the serratus anterior allowed the scapula to go into a glide, releasing the subscapularis allowed his glenohumeral to drop back into the socket. And with those two things, we could start the re-education process. And immediately knowing that the plan is that he's just going to continue working with Nichole and to continue with the whole body movement focus and then continue with his awareness and return to his functional activities, new activities. I think he will be surprised at how many new things he can do that he was satisfied with prior to the loss of movement. And now he's going to be really excited. He certainly was excited when we were working with him together. And he realized that he could have more range of motion. He wasn't destitute to have a limited shoulder range of motion. So while you are answering these questions, I would love for Nichole to tell us a little bit more about, maybe her next follow-up session with Adam and how that went and some things that you were working on with him.
Yeah, so it seemed like a lot of the range was still there, so it didn't quickly re-guard. So my session a week later, we did the work with the ball on the wall, and he was able to do it and get those ranges. We did forward facing, side facing, and at the diagonal. And for those, just from my observation of Brent working with him, and when he did a lot of releases in the subscapularis. So that's where I put my fingers just for some tactile feedback, which I think also helped kind of remind him not to just lift his shoulder blade so that, oh yeah, that area could open when I'm rolling the ball up. And that seemed to work well. So, Brent had said there was a lot of crepitus. In our previous sessions, there was no crepitus because it wasn't moving. And so that was an interesting thing to me in that first session afterwards, that when I just had my hands lightly there, I could hear and feel a lot of that like stuff just kind of crunching and moving in a way it hadn't before. So that was interesting. So I've had 2 sessions since Brent was here. So my most recent was actually yesterday, and we did some work on supine, like a supine scap series, working, pushing the bar overhead, controlling it back through, giving the similar tactile cue. Nice thing on the ooh, right? The shoulder blades are free to move. And it's definitely, I can really tell, because before the whole scapula would just lift when the arms went overhead. And now it's starting to have some of that upward rotation. It's not perfect in any way, but it's a huge improvement where I can see that those tissues have released and really feel good about, trying to at least maintain that new range and slowly adding in some strength building with that. So with the tower bar, I played around with resisting him in both directions. So resisting him pushing overhead, resisting him pulling back down, and doing different things to see, just kind of feel that out, where he still had that kind of closed chain or pseudo closed chain relationship where he had something he could hold on to that was creating a fixed arc. and playing around with the load in different ways, just to kind of see how that felt, see what happened. And I have some ideas of how to continue progressing it as well.
If you want to comment on anything popping up on the screen right now, as Pilates teachers looking at this and things that you did.
Yeah, I think that feeling secure in the movement is important. I do, and we had a discussion encouraging him to go see that therapist who is nearby, and to start having some of this more regular co-treatment. So I do think he needs to have, like someone says, supporting that myofascial release. I think he needs continued myofascial release, but not a ton, because we don't want to start that dislocation pattern again. So my thought would be, supporting what was released by maintaining that range of motion, slowly building up strength, right? Which is part of that reassurance that he can get more range of motion without pain and restriction, right? So we want to kind of reiterate that in his body that, oh, I can move here and it feels okay. And it's not a dangerous or scary place to be. I haven't started introducing weight bearing yet because I know that that's where he's most apprehensive. And I think it is because it was a posterior dislocation. So I haven't done any of that yet. I do think that once I can see him have more strength through that range, that we can start playing around with that. What other things do I see here? Yeah, definitely building trust. I think that's important and not pushing it too far. So I'm really just adding like a dose of some of this added range of motion so that we're still meeting his goal of maintenance in his whole body in our sessions, and maybe just adding a little bit of that. I think that is really important. Oh, and yeah, breathing. We've been doing a lot of breath work also, just from other restrictions through the rib cage, across the chest, things like that. So we've started doing a lot of getting the ribs moving more, understanding that that is a part of the scapular joint, the scapulothoracic joint is to get his thoracic spine. So we do work on thoracic mobility with things like book openings, push through a circumduction, prone breath or supine breath work. I don't have a ladder barrel. My go-to would probably be bridging on the ladder barrel with breath work, trying to find some of that release and opening, but we just do it on the floor, with him putting pressure on his sternum with the exhales, creating a little tactile cue and support to draw length through the crown of the head. So addressing that whole area for sure.
And you're continuing to use the OOV with him, right? Maybe talk a little bit about what you're doing with the OOV. Yeah,
we're not doing a ton on the OOV. The stuff I'm doing on the OOV is what Danielle had him working on. And Danielle's more experienced with the OOV than I am, so she's my resource there. But we do basic supine alternating arm arcs. Like Brent said, he's strong and he's a bigger guy, and we also need the load to help his arm come back. So we're doing 8-pound weights. So alternating arm arcs, doing I always get confused when I'm coming overhead. Yeah, internal rotation overhead, things like that, playing around with the rotation of the shoulder. We do this motion here, so kind of this fly motion, opening and closing on the OOV, and we do the snow angels. And we do the supine scap series on the tower bar on the OOV, so that his scapula free. We do, all of that. Protraction, retraction, elevation, depression.
Have you noticed a difference with him, in the OOV not having the contact on the scapula where it's floating, of him being able to feel and observe the difference from right to left or the changes in the scapular rotation?
Absolutely. So before, when we would do the alternating arm arcs, for example, every time his left arm would come over his shoulder, the whole thing moved. And now there's more ease and he can feel that opening. So we're emphasizing this sense of opening through this kind of upper side body. And I can give him some feedback here. I've been doing maybe some just gentle pressure and pulling down for the pelvis, so that we're kind of allowing that to open instead of the whole shoulder blade just lifting. So that's something that's definitely changed. I feel like The OOT is working more to our advantage now that he's had some of that release. That's a big thing I see. I have not done the sideline, which is something I'm thinking I might do in our next session to really see how this feels, because this is his more restricted range, which is the abduction range. So I want to kind of see how that's looking.
Yeah, I was going to give you a little hint with him, and we talked a little bit about it, but just little gentle oscillations with the TheraBand before he goes into the deep abduction, because you want the rotator cuff's job is to suck the head of the humerus into the fossa so that he can get that motion. And the reason why he has a hard time abduction is because it has to have the displacement of that subscapularis. And so if the rotator cuff is awake and doing its job, and that's the last thing you introduce, you're going to have a more successful abduction experience for him, where he feels like he actually has control and maintaining congruency when you're exposing that joint like that. I mean, it's a great exercise, but it is exposing the joint. So it's
which is why I haven't really done it, because it was just a little too much.
Yeah, I agree.
That makes sense.
Hey,
we do it sideline. So one of the things that Danielle was doing with him was after book openings, we did kind of like a version of a sleeper stretch where he pushes against me into external rotation, comes down, pushes against, and we just kind of do this little back and forth before flipping to the other side.
Again, subscapularis is an internal rotator. And so when we're out like 90-90 and we're letting our arms come down, you know, that subscapularis is sort of taut at that point in time. And then the external rotator is the other way. So, you know, that's actually the opposite. The external rotation is the stretch of the subscapularis, which is really good. You know.
So that's what we're working on, is kind of fatiguing out his external rotators to then go. So we're going into that internal rotation, but with the intention of he's pushing into external rotation, and then we're working into external rotation afterwards. We do like a pre-test and a post-test.
Yeah, that's beautiful. All right, so looking at functional tests, the next thing that, again, the whole idea behind the case study is for all of you to have a voice and to sort of challenge yourself and think of what kind of things would you test for him based on all the information we have. We know that he needs this, you know, a portion of this range of motion in his shoulder girdle. It's not urgent for him. What kind of tests would you want to look at? And I see some right off the top there, the goalpost. Prone shoulder flexion. Let's talk about prone shoulder flexion. What would be a modification to the prone shoulder flexion test in Adam's case? Nichole, how would you approach?
Well, I see it here on the list in the lower left, right?
Oh, there it is. Yep.
Yeah, so doing it supine. And I haven't even done it with him, because one of the first things I did with him that was on the list of stuff Danielle was working on him was that OOP work. And you know, it wasn't even coming. I knew that we couldn't go prone.
Yeah. You know what I find interesting? I love this exercise, and I do this with a lot of people that have, you know, inability to weight bear in their upper extremity, whether it's the wrist, the elbow, the shoulder. And of course, a posterior instability is probably one of the toughest ones. But if you use the wall or a countertop and you progress it where they start having little mini successes, and I would make that kind of a test something that's done after you've done sort of a wake-up call to the rotator cuff. So the more awake the rotator cuff is, the more likely you are to be able to maintain congruency where you wouldn't have that ligamentous stability. Now, we do the same thing. Think of ankle sprains. When ankle sprains are really bad and they've healed up, we'll have that person, that individual, use TheraBand and do all of their intrinsics and TheraBand exercises to get the ankle muscles to substitute the loss or the laxity of the ligaments. And like I said earlier, you can't just assume that the muscle strength is going to provide that. I tell my patients all the time, you'll have to do these exercises every day before you go on the basketball court. You know, he would have to do these shoulder girdle, rotator cuff exercises every day before he went and maybe lifted some weights or went rowing or started doing some other activities. We can't assume that the muscles maintain the congruency. He'd have to do those exercises all the time. So goalpost, shoulder, supine shoulder flexion, modified shoulder movement. These are all good functional tests for Adam to be able to look at. And the reason why they're so important is because he will start realizing how much better he is. Anytime we have a client and we use our tests, sometimes we don't use them appropriately. We test somebody and we tell them a score. But what I like to do is to test somebody and show them that this is the area we really want to improve with you, and to see you get stronger or more range or more control, more coordination. And then when you go back in a month and they see that their goalpost was here on the left side, and now it's here, it's still not all the way up, but he knows how to keep his shoulder down. He can feel it against the wall. His external rotation now is about 40 degrees. And he's, it's like when they can realize that these functional tests or assessment that we use as Pilates teachers are directly related to their ability to participate in their activities, are very powerful, tools for us to keep them motivated, keep them coming, keep them doing their home exercises that are incredibly important. All right, another question for us. What do you believe could help Adam regain left shoulder range of motion now? So we're getting in a little bit more details. We restored some of the range of motion, but he still has a loss of range of motion. We're working, or Nichole's working on being able to have access to the new range of motion. But let's get a little more particular and dive down a little more into the nitty gritty. And while you're writing that, I'm going to have Nichole maybe talk a little bit about her theories and strategies that she wants to do with Adam in the future.
Yeah, so some of the things I'm thinking of introducing would be some kind of loaded external rotation. So right now we haven't introduced any load. We're kind of having it be assisted into external rotation when we're doing book openings, when we're doing push through circumduction. I'm guiding his shoulder into external rotation and getting that passive range, so it's moving. And I haven't been able to give him that weight yet because everything compensates. So I'm thinking of adding some standalone load, very little load, right? Much less load than his actual arm, but starting to introduce some of that and start to see what that feels like for him. Maybe adding some slightly assisted shoulder flexion work. So using the tower bar, maybe using less and less weight until he can do it with just the bar, right, as a fulcrum, and then maybe start to add a little bit of, I'll probably just add some resistance myself in the beginning so I can kind of feel it out, and then maybe progressing into some other types of load. I want to explore some more work on the OO. So maybe trying some prone work on the OO with scarecrow type stuff, maybe assisted in the beginning, elevated enough, obviously, that he can move. But even just being in that position, just kind of seeing what that feels like for him and just pushing his elbows down. So probably not actually lifting his wrists off. That's something I'm thinking of playing around with, pushing his elbows down, rolling up, and just getting some of that integrated. Those are some things that I'm looking into. Maybe some regular style, old school external rotation, some kneeling arm work, some integrated work in that way. Maybe some kneeling arm work, serve a platter, where he's loaded, pushing out, has that feedback. Potentially seeing what something like hug a tree might feel like. Maybe even doing serve a platter, adding some more shoulder flexion. So those are just some things that I'm considering. I'm considering just calling Danielle and picking her brain about it too, about things that she might use to approach having worked with him. That's one of my other strategies.
You get to pick the 69 people that are on here that are giving you some ideas as well. I see some in here.
Definitely.
Nice. And if you're watching this as a recording, feel free to send us your thoughts and messages.
I love this sideline arms on the reformer with the Franklin ball. I like that a lot. That's something I think I'll definitely try.
Yeah, I think that's a great idea, trying to create that space underneath the armpit as they move. And just an idea, biomechanically, when we call the arm is in its loose pack position, so it's about 45 degrees and 45 degrees. And that's where you can create the greatest congruency. And that's where somebody asked about what is oscillation, right? So what we do is a very small range of motion with an elastic band coming from many different directions and doing a very short stroke of oscillation with the arm on its axis. So it's here or down low, but that wakes up that rotator cuff with an acceleration, deceleration. And that's what we could do in any of these positions that we're talking about or preparation. And I have my clients have a TheraBand inside the door of their car or at their desk or at the commode or where they watch TV or where they eat dinner, and just having that TheraBand there that they can just do the oscillations in different directions, just keeping the rotator cuff awake and the joint congruent. And then everything else falls into place. I mean, Adam is an athlete at heart. I mean, he has incredible capacity. And if he just felt like his shoulders were congruent, I guarantee you he would be doing more activity. He's had to come to a point where spiritually and mentally he's satisfied, where he is compared to where he came from. But I don't think he would turn away a little more movement and strength. He'd be pretty happy. Great information here. And just to give you a little insight, and this will be our last slide for discussion today. But I wanted to bring this up from the strategy standpoint, and Nichole brought it up right away. But Adam's belief that his left shoulder is as good as it's going to get. And it was met with a surprise that he could get more function and range out of it without additional surgeries. And so how we navigate that space in our communication, we don't want to discourage the patient or make them feel bad for being satisfied, if that makes sense. If they're satisfied where they are, it might even be a question of, if you had a little bit more range and strength without discomfort, would that be something you'd be interested in? And let it be their decision. And then to say, I think I can get you a little more range and a little more function and not have to have surgery for, at least not the near future. Is that of interest to you? Because there has to be something that sets the anticipation or the motivation for them. Now, right now, his motivation has been to maintain. And somehow we want to, as promoters of health and wellness, we want him definitely to maintain. So we definitely don't want to discourage that. But can we add a little better quality to his life with a little more range of motion and strength? His professional sports and manual labor have come to an end in his mind. It's not, he's not going to continue pitching and playing pro ball with his shoulders. And what will happen when he has more function in the left upper extremity again is the question. And so how we communicate and navigate that, I think, is a very sensitive area. I think a lot of times we make assumptions that everybody wants to do this. And maybe he worked really, really hard to become content with where he's at. And we do this kind of training with people who have spinal cord injuries, people who have terminal illness, people who've had amputations, to be able to realize, look, the leg's not going to grow back. The spinal cord up until now is not going to grow back. What can we do? What can we be satisfied with? Because that's where your happiness comes from. And so we need to be sensitive to that. We are out of time. Nichole, any last minute things you want to share about the case with Adam or things that you'd want to discuss with him?
No, just that I'm grateful that I have a community that I can reach out to help with these kinds of things, because, no matter how many years you're teaching, you're always going to see something you haven't seen before. I've never worked with someone with a posterior dislocation. And so I'm sure the approach is different and it's unfamiliar to me. And so to know that I can talk to Brent about it and say, this is what I would normally do when I see someone lack congruency in their glenohumeral joint, but it's almost always anterior. So what really changes? What's the mechanism? And, it's going to probably take me a second to really wrap my head around it. And, because I have limited time with Adam, I only see him once a week. And so much of it is that regular maintenance, what would be the most bang for my buck, or what things could I switch out that might be a better approach, knowing now that it's a posterior it's sitting more posterior, that he has that restriction under his scapula. So what would be the things to fill that in with? And then kind of building a plan to progress after that and make sure we're working the smartest way possible. Because I can try and problem solve it, but it's just, we all have these moments where like, this is something new for me. I'm seeing something new, and I'm gonna have to try a few different things and try a few different approaches and try to do that within this limited time that I have. You know, if I had 3 sessions a week, we'd be trying a million different things, right? I feel like I could grow really fast and understand this much better, but having, you know, of that 1 hour, maybe 10 minutes that I can try and add that extra thing. I want to, you know, really use my resources. Like I said, talk to Brent. I want to talk to Danielle, who's worked with him for a number of years, and just like, you know, this is the situation. How can we progress this in the best way possible?
Yeah, very good. Well, listen, thank you, Nichole, for your time and bringing the case. And I appreciated the opportunity to work with you on that case. We haven't done that very much. So it's not like Nichole and I are collaborating on every one of her cases or my cases. So that was wonderful. And I do want to emphasize the fact that build your team, like find, you know, make your community, and don't be discouraged if you come across somebody in the community that doesn't want to work with you. There is somebody that will want to work with you. We're always working in Polestar in particular to cross-pollinate. Like we want to have and see the beauty and the skill set of everybody in that spectrum of wellness and movement performance and rehabilitation. So it's very important that we made a decision a long time ago. We used to have a rehabilitation program and a studio program, and we decided a number of years ago that that's not what we are. We want the therapists and the medical practitioners to be working right alongside with the dancers and the movement educators, and to be able to have that cross-pollination and realize how beneficial the movement is from the mover and the movement instructor, and how beneficial the assessment and diagnostics and understand biomechanics are. And everybody can have knowledge. I think that was the thing I learned from Elizabeth Larkham and also from Shelley, is that everybody's entitled to the knowledge about the body. Are you licensed to make a diagnosis? Maybe not, but can you observe the natural sciences and the knowledge of the nervous system and the biomechanical system of the body? Absolutely. And so we encourage all of you. This is part of what Nichole's working on right now with our team, is to bring in more and more education that allows all of us as Pilates teachers, physical therapists, to gain greater understanding and insight to movement science. And trust me, the medical community does not have the greatest knowledge base on movement science. So a lot of times, you know, we are learning from the movers. We are learning from the movement teachers. We're learning from the movement scientists. So be that person, be that educated person. We appreciate you joining us. We do have something coming up pretty soon. This is Shelley and Nichole on the slide, but it's the bridge with Polestar. It's a transition intensive. If you in any way, shape, or form are interested and haven't gone through Polestar's formal training, we do a week intensive here at the farm in North Carolina, very easy access into RDU. That starts August 22nd. It's basically 6 days long with 1 day off. And you get a chance to work with Shelley, and that's a wonderful experience. And we get nothing but rave reviews of how you integrate your existing knowledge, your existing experience, and add more problem solving and understanding of how the movement really works in our bodies in the Pilates environment. Thank you, everybody, for joining us. We got lots of continuing education to come up. Make sure that when you opt in to get the newsletter, because it often has all the new courses that are coming out every month and other opportunities. And of course, that's free. We love sharing information for free. Share it with a friend. Most importantly, be kind. I do want to do a shout out. A good friend of mine, Lisa Leader, who usually is on this show, has had a family illness that is very severe. And without going into detail, just keep Lisa Leader, if you know her. She's a good friend of ours in Asia, Italy, the United States. Keep her in your prayers and your thoughts. We're a family, and we certainly believe in the energy of well-wishing and loving our neighbors. So be kind, and we'll see you next week with another Polestar Pilates Hour. Thank you, Nichole.